Hi, my name is Debbie Levine. I'm from Beth Israel Deaconess Medical Center in Boston and Harvard Medical School, and today I'll be speaking about fluid in too many spaces and places, fetal hydrops. So today we'll be talking about fetal hydrops. And my objectives are to illustrate the appearance of fluid in the different fetal body cavities, discuss the differential diagnosis of the etiology of hydrops, and discuss the use of middle cerebral artery Doppler in the assessment of fetal anemia, which is a frequent cause of hydrops. So what is hydrops? Well, it's an abnormal interstitial accumulation of fluid in body cavities, and those body cavities are the pleural cavity, the pericardial cavity, and the peritoneal cavity. Now you need two of these for a diagnosis of hydrops. Or you could have fluid in one body cavity along with soft tissue edema involving the entire fetus, Anasarca. A lot of people get confused by the term lymphangiectasia, and they'll frequently call a fetus early in pregnancy having hydrops when in fact it's lymphangiectasia. Lymphangiectasia is what you're seeing in this slide, when you've got a lot of edema in the subcutaneous tissues, but you don't necessarily have fluid in the different body cavities. So this is not hydrops. This is still a very, very poor prognostic feature. In fact, it would be almost unheard of for a fetus that looks like this with such severe lymphangiectasia to survive. Another finding that's commonly seen in hydrops, but not needed for the diagnosis of hydrops, is placentomegaly. Now in this slide, we've got a fetus who clearly has fluid in the abdominal cavity and who also has anasarca. You can see all of the edema in the soft tissues here. Here we're looking at the placenta, and these are our centimeter markers. And I'll tell you that this fetus was only about 20 weeks, and you can see that this placenta is about 3 centimeters. And in general, the placenta can be as thick as 1 millimeter a week, and so this would be much too thick. Polyhydramnios is another very common finding in hydrops, but it's not needed for the diagnosis of hydrops. And different people use different numbers for the diagnosis of polyhydramnios, an amniotic fluid index, for example, of greater than 20 or 22, or a single pocket of greater than 8. Well, let's talk now to what are the causes of hydrops. And many different etiologies can lead to hydrops. It's a late stage of many different processes that lead to redistribution of body fluids. And these body fluids redistribute among the intravascular and interstitial compartments. Here we can see a fetus with hydrops, and there's actually fluid in the neck, in the soft tissues of the neck. There's the anasarca, the soft tissue edema. There's ascites here as well, and you can see the very small appearance of the lungs. Here we can see placentomegaly. Again, you don't need that for hydrops, but you can see the skin thickening and the fluid in the pleural cavity outlining the lungs. Here on a sagittal view, we've got fluid in the neck. We've got a little bit of fluid around the lungs. This is the diaphragm right here. And then we've got fluid in the fetal abdomen. So the etiology is an imbalance of interstitial fluid, and this can happen for many different reasons. Heart failure, high cardiac output failure, decreased colloid oncotic plasma pressure, such as what we see in anemia, increased capillary permeability, and obstruction of venous or lymphatic flow. So let's go back a little bit and talk about how we actually figure out what fluid spaces the fluid is in, what body cavities the fluid is in, and how we know which body cavity these are. Well, one of the earliest signs of hydrops will be fluid in the peritoneal cavity, or ascites. And here you're going to see fluid around loops of bowel. So here we've got a view of the abdomen, and we've got bowel loops here, and we've got fluid around them. Here we're a little higher in a different fetus, and we've got the liver, and we can see fluid around the liver. And you also might see fluid outlining umbilical vessels. So here we're right just above the umbilical cord insertion site into the abdomen, and you can actually see the umbilical vein right here surrounded by fluid. And this can be very confusing if you've never seen the umbilical vessels outlined by fluid before. So you need to be able to recognize that umbilical vein in the abdomen. Now the umbilical arteries are next to the bladder, the fetal bladder. So what we can see in this image are the two umbilical arteries stretching back to go around the fetal bladder in this fetus with ascites. Now, if it's a male fetus, the fluid in the scrotum will actually communicate with the fluid in the peritoneal cavity, and you'll frequently end up with bilateral hydroceles. Now, I want to emphasize that hydroceles are very, very commonly seen in male fetuses, and they are not a sign of hydrops as an isolated finding. Pseudoascites is a term that you might have heard of. Every now and then, you'll see a hypoechoic area just below the skin, and you might think, is that fluid? Well, you need to remember that sometimes the abdominal wall muscles or the abdominal wall fat can look hypoechoic, they can look dark, and they can look like fluid. And the way you'll figure that out is by looking up and down and seeing if there's fluid anywhere else and recognizing the normal position of that hypoechoic band along the anterior and lateral fetal abdomen wall. Here's another example of a normal fetus, and we're looking at this hypoechoic band right here. And as we get further down in the abdomen, this hypoechoic band isn't extending into the interstices and along and around the abdominal loops of bowel, and that's how we know that this is a normal finding. And I wouldn't mention pseudoascites in a report because that might get the clinicians worried when indeed this is a normal finding. In fact, if you look up above the spine here, you can also see that this musculature is looking very hypoechoic. Another example of pseudoascites, right below the chest wall, abdominal wall here, seeing this hypoechoic band. Note that this doesn't surround the liver and it stops at the insertion of the ribs. Now sometimes we'll see ascites, fluid in the peritoneal cavity, and that's the only finding that we'll see. And if you remember what I said at the beginning of this lecture, you need fluid in two body cavities to be called hydrops. So if it's just in the peritoneal cavity, that's ascites. Now this can be an early sign of hydrops, but if it's truly isolated, you're going to think, what could cause that fluid? Now it could be a urinary etiology, for example, if there's an obstructive uropathy and then the bladder, one of the kidneys ruptures. It could be due to a GI obstruction, again with a perforation of a bowel loop and meconium peritonitis. If there's only ascites, this has a much more favorable prognosis than full-blown hydrops. But you do need to follow up these fetuses to ensure that hydrops does not ensue. Here's an example of isolated ascites, and you can see that this is a large amount of fluid in the abdomen. It's surrounding the bowel loops. When we look up in the chest here, we don't see any pleural effusion. In this case, the abdominal fluid was so much, and we weren't sure what the etiology was, that we actually did a fetal drainage procedure. This is something very, very rare to do for isolated ascites, but we wanted to give the lungs a chance to grow, and so actually wanted to decompress the fluid cavity. And so you can see this is basically an amniocentesis needle going into the fetal abdomen. Well, let's move on now to the chest and pleural and pericardial effusions. These tend to occur later in hydrops, and if they're isolated findings, they could be of a more benign etiology than hydrops. But you need to be able to tell the difference between a pleural fluid and pericardial effusion because, again, these have different etiologies and potentially different treatment. A small pleural effusion might be seen and might not cause any problem for the fetus at all if it's unilateral, and in this case we just have a little sliver of fluid around the lung and doesn't shift the mediastinum. The problem is that these small effusions can get larger, and if they get larger, they can actually cause mass effect. And once they cause mass effect, they're going to cause mediastinal shift. In these cases, you want to look for a hernia or another chest mass as the cause of the fluid. So here we are looking at the small pleural fluid in this fetus with an isolated pleural effusion. This is an example of a medium-sized pleural effusion, and what you can see here, this is the fluid right here, and here's the lung, and here's the heart. And the heart is actually not shifted very much in the chest. It's still in a relatively normal location, but this is obviously a fetus that you'd want to watch very carefully. Here's a fetus with a bilateral pleural effusion, And what you can see here is the so-called bat wing appearance, where you've got fluid around both lungs. And you can see the heart anteriorly in the chest. Now, if the fluid is very, very large, if there's a large amount of pleural effusion, it can actually cause compression of the lungs. And when the lungs are compressed, they can't grow and develop normally. And so this can be a cause of pulmonary hypoplasia. So if pleural effusions occur early and if they're long-standing, and if they're large and cause mediastinal shift, those are the ones that we might want to treat by doing a drainage procedure. You'll notice in this fetus that there's also a small amount of ascites, so this would count as hydrops. So here we've got large bilateral pleural effusions and a fetus with a large amount of soft tissue edema. So those two findings together would be enough for us to say this is a hydropic fetus. And you can see how compressed those lungs are in the central part of the chest, and you can imagine how that might lead to pulmonary hypoplasia. Now, sometimes the only thing that we'll see is a unilateral large pleural effusion. And in that case, the most likely diagnosis is a primary chylothorax. This is the most frequent cause of an isolated pleural effusion. And again, this can lead to respiratory distress in the newborn. What you can see in this fetus is that the heart is shifted over in the chest, that the lungs are compressed, and that there's a large effusion. So sometimes we'll actually drain these during pregnancy to help with development of the lungs, and sometimes we'll drain them right before delivery to help alleviate any immediate neonatal respiratory distress. So there's the heart shifted over. These are unilateral, they shift the mediastinum, and they flatten the diaphragm. Now, when you drain one of these large effusions, what you'll find is a large number of lymphocytes in clear yellow fluid. And you might think, well, how do you know then what the etiology is? And when we think about a chylothorax in neonates, usually that has a milky appearance, but the chyle doesn't actually become milky until after the infant feeds, and that's why in utero this will be clear yellow fluid. So again, we drain this fluid to help prevent pulmonary hypoplasia and to assist in peripartum care. Let's now move to pericardial fluid. This will be fluid around the heart. And one of the important things to know is that we frequently see a small sliver of fluid around the heart in normal fetuses. And unless this becomes large or looks like it's causing compression, it is not something to worry about. Here again, we see a normal appearing heart with just a sliver of pericardial fluid, not something that I would worry about. In this case, there's a lot of fluid around the heart. How do I know that this isn't a pleural effusion? How do I know it's a pericardial effusion? Well, what we can see is that the lungs are posterior here. They're being pushed posteriorly. And the fluid isn't going around the lungs, it's pushing the lungs posterior, and the fluid is around the heart. So you're not getting a bat wing appearance, you're getting the appearance of a heart floating in fluid. So pericardial fluid, the lungs are pushed backwards. Pleural fluid, the lungs look like they're floating in the fluid. The other thing that you can do is flip the fetus over, flip the mom, look at it from a different angle, and again you'll see that the lungs are always pushed to the posterior aspect of the fetus and the heart is floating in the fluid. Let's now turn to Anasarca. Now this is a fetus with obvious, very abnormal heart. You can see a large heart here. This is the etiology of the hydrops, but what we're looking at here is how thick and abnormal this subcutaneous tissue looks. It looks very, very edematous. Here we're looking around the head, and we're measuring the head appropriately because the head measurements are around the bone, not around the skin. But you can see how edematous the skin is here, looking here anteriorly. I do a lot of fetal MR, and I just thought this was a very nice example of what Anasarca looks like, and this is that same fetus that I just showed you. Obviously, there's fluid in the abdomen, and you can see the umbilical vein here, which I talked about earlier, umbilical vein right here, umbilical arteries going down low, bowel loops surrounded by fluid, fluid in the chest, and this is all the soft tissue edema, and you can see how much this looks like the amniotic fluid, and you can see how it totally surrounds the fetus. So how does hydrops affect our biometric assessment of the fetus? I mentioned earlier that around the head, we're going to look around the bone. What does it do elsewhere? Well, you want to be sure that you don't get faked out and that you really pay attention to how biometry should be performed so that you can accurately assess the gestational age. Now, different computers, different ultrasound equipment will calculate the gestational age differently. But as a rule of thumb, we usually take the 4 measurements by parietal diameter, head circumference, abdominal circumference, and femur length, and pretty much average them out to come up with a fetal gestational age. Well, you can imagine if there's a lot of Anasarca that you're going to get larger measurements if you go around the outside of the skin. And it turns out that for the abdominal circumference, we do want to go around the outside of the skin because we use the abdominal circumference to estimate fetal weight. But the definition of the head circumference and BPD, as I said before, is around the bone. Well, if you're estimating gestational age, then you need to go into your machine and take out that abdominal circumference so that you're not overestimating the age of the fetus. So here we've got a fetus with hydrops, and we're appropriately measuring around the bone, around the skull, and not around the skin. Here we have a fetus, again, with Anasarca, and for the abdomen, we're measuring around the skin, not around the bone. And when you look at that dating parameters, you can see that the head and the femur are about 19 weeks, 5 days, but the abdomen about 28 weeks. So again, you use the abdomen for an estimate of fetal weight, which makes sense because the Anasarca is contributing to the fetal weight, but not for the gestational age. So here we've got this date sheet of a different fetus who also had hydrops and had Anasarca. And what you can see is that the abdomen, measuring 34 weeks, is much further along than the average gestational age. And when you put that in, you're driving up the other numbers. And when you get an estimated fetal weight of 96%, it's because of that abdomen circumference. And then for the ultrasound age, we want to take out the abdomen circumference. Instead of using the abdomen in the calculation of the gestational age, we're only going to use the head measurements and the femur. Well, let's go back now and talk about causes of hydrops again. There can be immune hydrops or non-immune hydrops. And prior to the use of RhoGAM, immune hydrops was very, very common. In fact, it accounted for about 80% of all cases of hydrops. But now, at least in the United States, non-immune hydrops is much more common because we give so much RhoGAM. And so that gets rid of the immune hydrops cases, and it leaves the non-immune hydrops as being the common cause of hydrops 90% of the time. But we can't forget about immune hydrops because some individuals come in not knowing that they have an issue with Rh or with one of the other factors. So immune hydrops has also in the past been called Erythroblastosis fetalis. And it's when you have antibodies in the maternal circulation that destroy the fetal red blood cells. This will lead to fetal anemia. The liver and the spleen become large. You'll have increased erythropoiesis, hypoproteinemia, and ultimately congestive heart failure. Maternal Rh sensitization occurs during fetal maternal hemorrhage. So this can occur at delivery, so it won't affect a first baby, it will affect a subsequent baby. But it can also occur after a miscarriage, spontaneous abortion or therapeutic abortion. You can have mixture of the fetal and maternal blood. And sometimes women won't have known that they had a spontaneous abortion earlier on in life. They'll just think they had a delayed or a heavy period. And that's how somebody during a so-called first pregnancy can have Rh sensitization. You might do an amniocentesis early in pregnancy and cause some fetal maternal hemorrhage. Abruption or incompatible blood transfusions can also be a cause. Transplacental hemorrhage can also occur. In fact, it's very common in many pregnancies, but it's usually just a very, very small amount. And this is another reason why somebody with a first pregnancy might come in with Rh sensitization if they had a transplacental hemorrhage. And it turns out that if you have a D-negative woman, that if she's had bleeding like this, there's a 3% risk of sensitization. So we give RhoGAM when we think the patients need it, and the dose is given there, 300 micrograms at about 28 weeks, and that protects against 30 milliliters of fetal blood. If there's been a greater degree of fetal maternal hemorrhage, you can do a very, very old-fashioned test that's still around, a Klein-Hauer-Becke test, that's utilized to quantify the amount of fetal blood in the maternal circulation, and you can actually calculate the dose needed. Let's now turn to talking about the atypical antibodies. Rh is the one we all hear about, but there are many, many other antibodies that can cause immune hydrops, and these develop in 1 to 2% of individuals after blood transfusion. And they account for about 2% of hemolytic disease of the fetus, but of course that number changes as the use of RhoGAM increases. So the common antibodies that we think about are the Kel, the RHC, and the E. We also need to remember, if you have somebody who you know is Rh negative, and if you're doing some kind of invasive procedure to the fetus, that you need to give RhoGAM. You don't need to give it that minute, but you need to give it within 48 hours. Now, in some cases, if the mom is known to be Rh negative and the father of the baby is Rh negative, you don't need to give RhoGAM. Other people feel more comfortable not being sure who the father of the baby actually is, giving RhoGAM to everyone who is Rh negative. So in the past, when we were screening for Rh sensitization, we would determine the Rh status of the parents. We would monitor antibody titers and look for antibody titers of 1 to 8 or greater. We would determine the Rh status of the fetus. That would have to be an invasive test. Do an amniocentesis for the optical density, which was increased in hemolysis. And then if there was a suspicion of anemia, we would do the PUBS procedure, percutaneous umbilical blood cord sampling. And you'll notice a lot of this is very, very invasive. Nowadays, though, we look at the MCA Doppler, and I'll be talking about that in a little bit. Let's now turn to non-immune hydrops. In Southeast Asia, this is commonly caused by being homozygous alpha thalassemia patients. So the carrier status is very, very common for alpha thalassemia in Southeast Asia. It occurs in about 5 to 15% of the population, and it accounts for 60 to 90% of non-immune hydrops in this region and a quarter of perinatal deaths. In the Caucasian population, who I usually deal with, we see this in about 1 in 3,000 live births, non-immune hydrops. And alpha thalassemia is not the common cause. So again, where you are in the world is going to determine how you think about hydrops. In the Caucasian population, cardiac abnormalities, infection, and karyotype abnormalities, in particular Turner syndrome, trisomy 13, 18, 21, and triploidy are the common causes of non-immune hydrops. And why will this occur? Well, usually because of increased hydrostatic pressure. Primary myocardial failure, arrhythmias, anemia, twin-twin transfusion syndrome, myocarditis, heart malformations, and high output cardiac failure, such as can occur when there's an arterial venous shunt. You can also have hydrops because of decreased plasma oncotic pressure, for example, in a fetus who's very sick with hepatitis. Cirrhosis, which is pretty uncommon in the fetus, would cause decreased albumin formation. And then this very rare finished nephrosis, where you'll actually have increased albumin excretion. You can have increased capillary permeability, such as with anoxia or infection, or obstruction to lymphatic flow, such as can occur in Turner syndrome. Or, and commonly, you might have some combination of the above. Let's talk about cardiovascular abnormalities. Again, in the Caucasian population, these would account for about 20 to 40% of non-immune hydrops. Now, it's rare for an isolated cardiac abnormality to cause hydrops because in the fetus there's that parallel blood flow circulation. But in karyotypically abnormal fetuses, there are other factors, with or without cardiac abnormality, that can lead to hydrops. When we talk about fetal arrhythmias, we're not talking about the isolated atrial beat that comes early. But it would usually be one of the tachyarrhythmias, so that the heart is beating very fast for prolonged periods of time. Here's that fetus I showed you earlier with a very, very abnormal appearing heart. Obviously, congenital heart disease is causing part of this problem, and you can see the severe skin edema and the pleural effusion. Here in the abdomen, the large amount of ascites. And here around the head, the soft tissue edema. Here's this fetus, fetal MR, again showing the ascites, the pleural fluid, and the skin thickening. Cardiac tumors can also cause hydrops. Now, cardiac rhabdomyomas are one of the more common cardiac tumors that we'll see, usually in association with tuberous sclerosis. It's not the tumor itself that causes the problem. It's usually going to be the location of the tumor and if it causes obstruction. And that can be diastolic filling impairment, alteration of the function of the AV valves, or outflow obstruction. So it's the location, the size, and the number of the lesions that are going to correspond to the risk of hydrops. A very rare pericardial or cardiac tumor would be the mediastinal teratoma. And again, because of the size of these lesions, because they compress the heart, sometimes if they have an AV shunt, they can cause hydrops. This is that fetus with a large pericardial teratoma. And it's really hard to even tell what's going on in this case. I'll point out the tumor to you, and you can see it right here. And again, right here, you can see the ascites in the abdomen. The ascites in the abdomen and this large pericardial tumor. Tachyarrhythmias we define when the rate is sustained above 200 beats per minute in the fetus, and these are usually going to be a supraventricular tachycardia. The diagnosis is important since the treatment can actually reverse the cause of hydrops. And it's very, very rare for us to have a curable cause of hydrops that we can take care of. So if a tachyarrhythmia is the cause of hydrops, it's important to figure that out. Some people would think, well, why don't we just deliver the baby and treat it outside? But it turns out that if you have a premature fetus with a tachyarrhythmia, it can be very, very hard to take care of that infant. So they'll often try and treat the mom to treat the fetus and avoid delivery of a hydropic preterm fetus. In this case, with a tachyarrhythmia of 240 beats per minute, they treated the mom with digitalis and then amiodarone, and the spontaneous tachyarrhythmia resolved. GI disorders can also cause hydrops. They can cause this by being a local obstruction to lymphatic and or venous flow. So you might see that in a GI obstruction of volvulus or an omphalocele. Frequently you'll see meconium peritonitis. But as I mentioned earlier when I was talking about fluid just in the peritoneal cavity, these GI disorders usually cause isolated ascites and not hydrops. Here we're looking at a fetus with an omphalocele, and I'll get my arrow here. I've got the cursors around the omphalocele, and you can see a little bit of ascites in that sac of the bowel and liver that's been extruded. Renal anomalies are a rare cause of hydrops, but again, as I mentioned before, can cause fluid in the retroperitoneum or peritoneal regions. So bladder rupture can occur and cause urinary ascites, but very, very rarely hydrops. Here we've got a nice picture of a keyhole deformity in a fetus with urinary outflow obstruction that later on led to ascites with urinary bladder rupture. I mentioned before that aneuploidy can be a cause of hydrops. If you see a fetus with a large cystic hygroma, you're going to think about an aneuploid etiology for the hydrops. Here we can see the skin thickening. Here we can see a very short femur. And here we can see fluid in the thoracic cavity and an anterior abdominal wall defect. You're going to definitely think about one of the trisomies or Turner syndrome in this case. Let's spend a minute looking at the biometry. You can see that by her dates, she's 15.5 weeks. The head size, again, we're measuring around the bone, is going to be about 15.5 weeks. The abdomen, we're measuring around the skin, so it's 19 weeks. And the femur length here is short, 14 weeks. It's still a straight bone, it's morphologically normal, but it's short. And that's another finding that we might see in aneuploidy as a cause of hydrops. Twins. Well, twins can cause hydrops for many, many different reasons. First off, twins have a higher incidence of congenital abnormalities than do singleton fetuses. The reason why someone's having twins, an older age woman, for example, or assisted reproduction technology can also lead to increased twins and increased congenital abnormalities. If you have twins who share a placenta, they're also at increased risk for twin-twin transfusion syndrome. And the recipient twin can end up getting hypervolemia, polyuria, polyhydramnios, and ultimately hydrops. Here we can see a case of twins. You can see the membrane between the two sacs, and you can see that sac of B is very large compared to the sac of A. Of course, you'd have to look all around to make sure that that was a constant finding. You can also have the so-called acardiac twin, where the pump twin is doing all the pumping for its co-twin who doesn't have a normal heart. That pump twin can go into high output cardiac failure. The acardiac twin will end up with Anasarca, not true hydrops, but Anasarca with all of the skin thickening. So here we've got the look of the acardiac twin, and you can see how thick all of this skin is with that Anasarca. You don't have the normal development of the brain since most of the blood flow is going to the lower extremities and abdomen of this acardiac twin without a functioning heart. Other causes of hydrops, and there's not enough time to go into these in detail, are skeletal dysplasias, metabolic disorders, and syndromes. Let's talk a few minutes about tumors. The tumor itself is not causing hydrops, but the increased blood flow associated with the tumor can. So if you have a tumor that's very, very vascular and has arterial venous malformations, this can lead to high output cardiac failure. And it can also lead to a consumptive cardiocoagulopathy, also called the Kasabach-Merrick sequence. You can also have teratomas that just plain have increased flow, and because of the increased flow, they can lead to the AB shunting and this Kasabach-Merrick sequence. People also talk about mirror syndrome. And what is mirror syndrome? Well, it's when the mother gets sick, mirroring what's happening in the fetus. So you get maternal anasarca in a pregnancy complicated by fetal hydrops, and this can actually be life-threatening for the pregnant woman. So what you will see is massive edema, oliguria, and hemodilution. We definitely don't want to miss this. What are the causes of fetal anemia? Well, the first one would be that there's excessive loss of blood cells, such as what you'll see in alpha thalassemia. Again, you're going to think about that in people from Southeast Asia. You can have extrinsic hemolysis, for example, as I mentioned before, in AVMs and tumors. You might have a reason that the fetus bled a lot, trauma, for example, or you might have infection. The infections that we think about are parvovirus, CMV, syphilis, and toxoplasmosis. Now, hydrops in these cases can be reversible without any treatment, but they can also cause other associated abnormalities. For example, with the torch infections, we can see calcifications in the pericardium, the brain, or ventriculomegaly. Infection will lead to high output failure for one reason, by anemia, but it can cause other problems that can also lead to the hydrops. For example, it can cause a liver inflammation, hepatitis, inflammation of the heart, myocarditis, and full-blown sepsis. Parvovirus is going to be the most common infection that we'll see, and we can test this looking for IgM in the maternal blood or high or increasing IgG. Or nowadays, we will tend to use the PCR identification of the parvovirus genome in the amniotic fluid. If you do a tap of the fetal cord, a chordocentesis, you'll see anaplastic anemia with few reticulocytes. What we do when we see parvovirus, when we know that the mother's been infected, is that we'll end up doing very, very frequent scans of the fetus in order to check for signs of hydrops. And here we can see a fetus that's been exposed to parvovirus, and we can see a little bit of fluid in the abdominal cavity, and just a very, very tiny sliver of a pericardial effusion. This is the kind of fetus you would watch and not necessarily intervene on. Further on in gestation, again, you can see pericardial effusion here. You can see that the heart is not beating very well. I have images here labeled diastole and systole. You don't see a lot of contraction during systole because there's a myocarditis going on. What do? Weekly serial ultrasounds for 8 to 12 weeks after the maternal infection, assess for signs of hydrops, perform Doppler for analysis. What is this Doppler that we're doing? Well, it's the middle cerebral artery Doppler. And we're looking at the cerebral circulation. This is normally a high impedance circulation, and it has continuous forward flow. Just think about it. The fetus wants to protect the brain. It wants blood flow going to the brain at all times. Why do we do the MCA? Because it's a very accessible cerebral vessel. It's very reproducible, and it carries the vast majority of the cerebral blood flow. When a fetus becomes hypoxemic, you get central redistribution of the blood flow. You get increased blood flow to the brain, and the peak systolic velocity goes up. So here we're looking at the circle of Willis in the brain. Let me get my arrow to come here. So here's the arrow. This is the MCA right here, and we're putting our Doppler gate on the MCA, and we're measuring the peak systolic velocity. There are charts to look up what the peak systolic velocity is with respect to gestational age. Gestational age is very important, so you want to make sure that you're assessing the gestational age appropriately. Usually you're going to use the head measurements if there's a problem with the abdomen or the femur. And it turns out, if you look at this, MOMs are multiples of the median, that as you go up and get above 2 multiples of the median, you almost certainly are dealing with anemia. So again, you look at the circle of Willis. You get a transverse plane of the fetal head at the base of the skull. You put your Doppler gate in the longitudinal view, almost parallel to the ultrasound beam. The prognosis in hydrops is grim. Once a fetus is in full-blown hydrops, 70% will end up dying, 100% if there's a structural abnormality identified. If a fetus is anemic, then it's actually possible to reverse the hydrops by doing a transfusion, but not always. And what's interesting is that sometimes, even if there's anemia, if you don't transfuse the fetus, the hydrops may still resolve spontaneously. And you can think about that. Maybe the fetus was ill and had some kind of viral infection, was able to fight that off and got better. So if you don't do a transfusion and anemia is the cause of the hydrops, about a third will resolve spontaneously and about a third will die in utero. If you do a transfusion, you can improve the odds and have about 53% resolve and 17 or 18% die in utero. So it's not a cure-all. Transfusion is not going to cure the problem. The fetus will still be sick. But what's interesting is that if you do a transfusion, that's not necessarily all the reason why the fetus got better, because a lot of them will resolve spontaneously. How do we do this procedure? How do we find out if the fetus is anemic? Once we've done that MCA Doppler, we actually need to get into the umbilical cord to check the actual hematocrit. So we're going to look at the placenta and look at the cord insertion site into the placenta. If you go for a free floating loop of cord, it can be very hard because the cord moves around. So where we like to go is right near the placental cord insertion site, and we want to go right into a vein there. So you want to use packed red blood cells, meaning that the blood cells that you're transfusing have a hematocrit of greater than 90%, and that's because you don't want to give too much volume to the fetus. And this will be O-negative irradiated blood. And your goal is to reach a fetal hematocrit of 40. So here we are doing an MCA Doppler, and we've got our systolic right here, and that's at 53 centimeters per second. So this is a fetus at 26 weeks with an elevated MCA Doppler. This is a fetus who might benefit from a PUBS procedure. Here we are looking at the cord insertion site into the placenta and picking an appropriate location to put our needle. And here we are going into that particular location. Here we've got a fetus I showed you before with hydrops, skin thickening, pleural effusion, omphalocele, definitely abnormal. Doing a PUBS for this fetus is not going to be helpful. So again, you need to figure out who is going to benefit from an invasive procedure, and only do it when you have a high suspicion of a curable cause of hydrops. Like I said when I discussed this fetus before, there was a short femur, which is going to make you think of a karyotype abnormality, and a cystic hygroma, which is going to make you think even more of Turner syndrome. And so definitely think about chromosome abnormalities in these kinds of fetuses. Lymphangiectasia I mentioned before, because it's almost universally fatal. You want to make sure that you can recognize it and use that term appropriately. It turns out that these early fetuses with lymphangiectasia have chromosome abnormalities in 2/3 of the cases. So let's summarize for hydrops. The diagnostic approach, you need a maternal history. Depends where the mom is from, so ethnicity is important. Maternal blood type is important to think about isoimmunization. Diseases that you think about are anemia and infection. Consanguinity can lead to anomalies, so find a history of both the pregnant woman and her partner. Family history is important, as is medication use. Obstetric history would include looking for affected siblings and any history of prior abortion or stillbirth. The maternal studies that might be considered being done is blood group typing, an indirect Coombs test, a CBC, the Klein-Hauer-Betke test, and testing for infections, syphilis, parvovirus, CMV toxo, and others that might be thought about due to the patient's history. The diagnostic approach is to start with ultrasound. Ultrasound is a wonderful tool, but in many cases we can't find the cause of the hydrops. In fact, that turns out to be about 15 to 30% of the cause. Echocardiography is important because the heart can either be the primary etiology or can be secondarily involved in hydrops. Amniocentesis is important for the karyotype abnormality. You don't want to do a transfusion in cases of lethal karyotype abnormalities. You might want to check the alpha-fetoprotein. Antigen tests by PCR, culture for syphilis, testing for CMV and toxo, or others as suggested by history. You want to do an MCA Doppler, and if that's elevated, consider doing the percutaneous umbilical blood cord sampling. The follow-up, getting the best diagnosis is going to be important, not just for the current pregnancy, but also to be helpful in counseling regarding recurrence risks in future pregnancies. So thank you very much for your attention.